All right. Thank you very much, Jens. It's a treat to be here. I always enjoy coming to the Seattle Science Foundation. Bear with us just for a second while we're pulling up our talk. But it's always exciting to be able to see the minds that are functioning here and the way it's working. And when we get to this talk, we're going to talk a little bit about that intersection again of big data and artificial intelligence that I think Sig already touched on a little bit this morning. And for the first time, we're really being able to gather data at every single level of our spinal correction. And whether that's appropriate or not, our hope is that obviously we can start organizing our patients into sub-cohorts, and we can stop looking at the average patient and start looking at more patient specificity. And that's really the point of this talk, right, is to look at the current state of patient-specific implants, look at controversies, look at claims associated with these, and really decide for ourselves, is this the way that we're going to go next? And so several disclosures, the most of which is receiving research support to our organization through Carlsmed, which is one of the companies that supplies patient-specific implants. But what is really meant by a patient-specific implant? What are the goals of this approach to our patients? And what technologies are considered to be patient-specific implants? And then what are the controversies associated with it? And really, what we're asking is, how do we take a patient that looks like the patient on the left and hopefully deliver a surgical outcome that arrives at the patient on the right? Right? And we're all different. We're all unique. That's the point of the Bruce-Lee classification, is sit there and say, even in the realm of normalcy, our spines don't necessarily look normal. And we have a number of spinal parameters, and I will tell you that this is a bit of a moving target. For those of you that are involved in SRS or otherwise, it seems we always go to a meeting, and every 2 or 3 years, there's a new alphabet soup that we had ignored for our previous career, et cetera. And now this is the latest and greatest in what we're supposed to do. So is it possible that we can develop an approach to our patients that can take all of that into account, that can analyze that big data, and then hopefully provide a prescription so that on the day of surgery, we're not just sitting there thinking on the fly, how are we going to correct this, but hopefully executing our preoperative plan and be able to deliver on that. So I kind of, broke patient-specific approaches into really patient-specific rods that are on the market at this point, patient-specific interbodies, and then enabling technologies. And I've spent a lot of my career speaking on enabling technologies. I'm not really going to cover that in detail, but I want to get into some of the nitty-gritty of the outcomes associated with these patient-specific approaches. And so, every patient, again, is different. And so there's a relationship between us and the patient. I really enjoyed the lectures that we had this morning on shorter constructs and our conversations we have with the patient to build that relationship. And this type of approach isn't going to be something that every patient is going to buy off on, right? A long segment fusion to correct this type of deformity. And so we need to make sure that we're realizing both the patient's intraoperative goals and ours. And so if we look specifically at patient-specific rods, and what's interesting to me is I was taught by a very good surgeon how to bend these rods. It was Dr. Chapman sitting here in the front. I was always impressed by how he could sort of match what we thought was necessary for the patient to the rod bending and then be able to deliver on that. And so, from that time forward, I kind of believed in anatomic placement of pedicle screws and then reducing the deformity to the rod system. And that's been very successful. But how good are we outside of Dr. Chapman at bending these rods? And this was an article by Dr. Ames in which they looked at there was a tendency to overbend rods by almost 20 degrees when given to a surgeon and say, okay, bend this specific degree. We improved pretty dramatically when we were giving it a template. And so this is kind of the issue, saying, okay, if we can plan beforehand exactly what we're trying to affect in the patient for deformity correction, and then we can deliver on that plan, are we going to be able to improve? And of course, that opened the door for patient-specific rods and companies that concentrate on these. And it's essentially a partnership, hopefully between the patient, the surgeon, and an engineer to be able to deliver a product that's going to aid intraoperatively in delivering this. And have we done so? So recently published was a meta-analysis of 7 studies that met the criteria, 304 total patients. And they looked specifically at SVA in 7 of the studies, PI-LL mismatch in 5 of the studies. 3 of the 7 studies found improvement in those things. And so while there is a a tendency to say that if there are things that we're following, if we're studying, we're able to improve those things, but there's an absence of robust randomized controlled trials in regards to this approach to patients. And so while we see very promising preliminary data, the future is going to help us understand how much this actually helps. We can also look at patient-specific interbodies, and there's a couple theories as to why this would work. And essentially what we do is we take similar technology to what we learned about this morning. We segmentalize the spine. We orient it the way we would like those segments to be oriented, and then we have a space in between those in which we 3D print an interbody that will accommodate the deformity correction that we're trying to affect for the patient. And theoretical benefits to this, right? Here are complications associated with deformity correction: PJK, PJF, pseudoarthrosis, adjacent segment disease, cage subsidence, rod breakage, et cetera. And these are the causes of those complications. And so if we look at the concept of something that fits our interbody a little, or that interbody space in which we're desiring to create for the patient, then these are the potential biomechanical rationale behind that. Does it work in real life? First off, if we look at end plate irregularities, this is very common. Even in the patients that we're going to see from either degen or deformity, no one really has an off-the-shelf end plate, unfortunately, and the highest degree of irregularity is L4-5 and L5-S1. And if we look at stock implant interface, even with a relatively normal end plate, you can see how we get point loading, especially along the anterior and lateral margins of that disc space, whereas if we can have an anatomical interface, we decrease that point loading, and obviously we hope to reduce the amount of subsidence associated with that. We're also abysmal at creating the lordosis with our stock implants, in the sense that if we sit there and say, I need to be able to create 37 degrees of lordosis from L4 to S1, because that's what I'm being told this year at SRS or otherwise, how good are we at doing that? We can't just take a 12-degree cage in which we end up on average with 1.6 degrees of correction and say, okay, that's going to translate into 12 degrees of correction. So it becomes important to sit there and say, is there a patient-specific approach? Is there something that maybe will help us be able to do this? And so there have been several studies, and this is going to be a little bit alphabet soup and a lot of numbers thrown at you, et cetera, and hopefully this will make a little bit of sense. But we started out looking at intervertebral lordosis, just looking at one segment, saying, okay, can we accomplish our goal with one segment? And if you look at this combination of ALIF, lateral, transfemoral lumbar interbody fusions, it turns out that we were able to become very close to accomplishing within 5 degrees of our plan 86% of the L-lifts, 83% of the T-lifts, and 79% of the A-lifts. And what was kind of surprising to me is that when we missed with both A-lift and L-lift, we had a tendency to overcorrect. And this picture on the bottom right kind of exhibits sort of the difference as far as that point loading with an off-the-shelf device versus something that is more patient-specific implant. If we look specifically at distal lumbar lordosis, so we look specifically at L4-5 and L5-S1, how good are we at recreating distal lumbar lordosis? And with a plan to correct distal lumbar lordosis, we were able to restore within 10 degrees, 94% to our plan, and 70% within 5 degrees. And what's sort of interesting about this also is if you were to look at people that approach surgery with a a normal distal lumbar lordosis, we were able to preserve that quite well if that was part of the plan. And in folks that had deficient preoperative distal lumbar lordosis, we were able to restore that in the grand majority of the patients. And so this is that same in a numeric format. In 84% of the patients that presented with normal distal lumbar lordosis, it was preserved. 73% was able to be restored. What's interesting about this is if you actually see the plan, which is the black number underneath the green number there in the mid column, there were several surgeons that didn't plan to restore that distal lumbar lordosis. And as it turns out, if we plan to not restore the distal lumbar lordosis, we're quite good at not restoring distal lumbar lordosis. And so looking at that is critical, and we hope that by being able to restore that ideal portion of the spine, that we're going to have fewer implant-related issues and post-operative related issues. Last year at this forum, I also presented a lot of data in which we looked at sagittal realignment. So now we're moving from one segment, or just the distal lumbar lordosis, and we're looking at sagittal balance in its entirety, and this was published in the IJSS last year. But we looked specifically at the Schwab Schwab criteria, of which there's three: PI minus LL, pelvic tilt, global alignment. And we looked at our constructs in which we were planning to correct these, and looked at, one, how well we affected those criteria which affect the severity of a sagittal deformity and our global rebalancing for these patients. And as it turned out, we were very effective at reducing the PI-LL mismatch. We were quite effective at restoring coronal alignment through a T1 PA, but we weren't nearly as good at restoring pelvic tilt in these patients. And what's interesting is if you actually look at what we're looking at from an engineering or surgeon standpoint, we're specifically looking at lumbar lordosis. And this leads us then to start looking at other issues associated with this. And so we were able to improve the overall alignment fairly dramatically in a number of the patients. And in fact, 38% of the patients improved from a moderate to severe deformity to a mild deformity, which at first take, you say, wow, that doesn't sound like much. If we compare it to historic literature in which only 13% of these patients are improved. And across the board, we had a 10% increase in lumbar lordosis. And so it also goes to show that if this is what we're looking at, if it's the parameter we see, then we're very good at meeting that parameter. What's important about studying these things is we find the parameters that we're not as good at meeting and then try to develop engineering ways to get to that point that we can improve those as well. And if you look specifically at the levels that were treated by a personalized interbody, then the lion's share of the correction was done through those levels. And that's what the white of the bar graph represents in this case. And so we had very few reoperation rate in this patient population, 1.5% of our patients, which compares favorably to 9.7% mechanical issues in the first year. And so we were able to say that there's a direct impact on lumbar lordosis, and that we're not as strong at coroning, at completely controlling and predicting sagittal realignment associated with these procedures. And so obviously these are patients with only 1 year of follow-up, and we need a lot longer term follow-up to establish whether there is a benefit over time with these. And then just recently submitted the Global Spine Journal. We looked specifically at the mechanical complications associated with the use of these interbodies. And we were able to compare this to our ISSG data, in which in these particular implants, we were able to achieve our goals within 2.4 degrees on average of our goal for lumbar lordosis, 0.2 degrees of the distal lumbar lordosis, 2.4 degrees of the PI-LL mismatch, and then within 0.3 degrees of our L1PA. And this resulted in 4.3% issues in the first 2 years requiring a reoperation, as opposed to 16.6% in the ISSG data. So it just goes to show that if we're able to deliver on our realignment goals, that those patients are likely protected from problems within at least the first 2 years after surgery. And then this is where it gets a little bit tougher, a little more esoteric. We took the same patient population that we looked at sagittal alignment and began saying, okay, can we look at our coronal realignment goals? And it's important to actually be realistic as to what a personalized interbody can do as far as coronal realignment is concerned. In fact, the algorithm that we work with the engineers doesn't take much coronal realignment into consideration, with the exception of the intervertebral coronal angles. But we decided that we could look at that intervertebral coronal angle, we could look at fractional curve correction, and look at Cobb corrections. And when we define the severity of coronal deformities, there are two main ways to do so. One is the Schwab criteria, any curve greater than 30 degrees, versus the Q or BOW type classifications, which have been mentioned several times today. A BOW A, which is within 30 millimeters of the CSVL, or a BOW B or C, which is outside of that range. And so we wanted to look at those as far as rebalancing is concerned. And specifically looking at the patients that are the levels, I should say, that we're actually using these interbodies. So if we looked at the intervertebral coronal angle, we were able to correct this fairly reproducibly within 78% of the patients. And you can see we had a tendency towards overcorrection in these patients as well, according to our preoperative plan. If we looked at fractional curve, there was 109 patients that had interbodies placed from L3 to S1, and so we wanted to look specifically at that subset of the population and see how we did. And correctional coronal malalignment in the fractional curve was improved by 8 degrees, and the lion's share of that was improved on the levels that were treated with a patient-specific interbody. And then finally, if we were to actually look at rebalancing, either through Schwab, et cetera, if we look at the fractional curve subcohort that we corrected the fractional curve, we're able to restore all of them from severe Schwab deformity to less than 30 degrees of curvature. And then if you looked at rebalancing, only in 6 cases were we able to restore someone who was either a B or C to a bow A. And we see that with the entire deformity cohort as well, in which the majority of the folks with preoperative coronal imbalance were improved, but not corrected to a bow A. And so our final conclusions is that we can very reliably predict what we're able to do at the single level that we're treating with a personalized interbody. Less reliably can we look at this as a prediction of the construct, and it gets down to the idea that both sagittal and coronal realignment is difficult. It requires more than just a special widget, requires more than just a special screw, et cetera. There's more to it as far as what we're doing. And so this is kind of a typical patient of mine that I'll use a technology like this, someone with significant bony loss, someone who's had an L2 to 5 fusion with adjacent segment degeneration both above and below. We come up with a plan and say, okay, if I could reorder the spine, reorient it how I want to, this is what I would put in the interbody space. We 3D print that device. You can see what that looks like on the CT scan in between stages, and we end up with this final result. And what's interesting, if you look at this just from a coronal rebalancing question, we've essentially shifted someone from the right-hand side very slightly to the left-hand side, right? And so it gets to the hardship associated with coronal rebalancing with these interbodies. So we have the whole alphabet soup, and when we look at any one of these factors all by itself, we can very effectively affect these levels, but I would take care in assuming from that that's going to allow for a global realignment with where we're at in the technology at this point. And planning can be time-consuming. That's one of the critiques of these. I don't find it particularly time-consuming. I'd rather do that at a time when the patient is not asleep and bleeding on the table. That's advantageous for the patient, so on the day of surgery, I'm just executing the plan. The implants themselves are expensive, and I think until something dramatically happens in this space, they're going to continue to be expensive. And so we really need to look at long-term case-controlled data and see if there's a cost-benefit analysis associated with this. And I think if we specifically concentrate on reoperation rates and look at hopefully the reduction in reoperation rates, we'll be able to demonstrate that, but that's hard to say, and it's going to need longer-term follow-up before we can even comment on that definitively. So I'd just like to open up for questions.
Excellent, beautiful slides, and nice to see data from a very well-controlled surgical center. I misspoke it before, but can you go back to that last slide of the, go forwards again. Yeah, the great case, go forwards, and yes, here. How much of this is actually the custom-made implant versus surgeon? So if I concentrate on that bottom center coronal view, I see a nicely, it would have been nice to have that pre-op one directly there that you showed just 2 slides earlier, but that collapsed disc and that kind of a concave side with hypersclerotic end plates. How much of, if you're really honest, is that the benefit of a custom-made implant versus a good surgeon who knows how to release a concavity, get the syndesmophytes cracked off, and then puts an implant in a strategically suitable position? Just honest answer. This looks like
I think that's a great question.
A great surgeon.
If I was looking specifically at L5-S1 on this case, I would agree 100% that if I had properly remobilized that L5-S1 segment, I probably could have gotten away with an off-the-shelf implant right here, looking at the coronal rebalancing of L5-S1. And then I would say, let's look at the segment right up above it, right? Where again, we had to remobilize this L1-2 segment where there was a massive erosion of the bone at L1. And, I kind of harken back to, the general orthopedic days or working with knee replacements, et cetera. And when you'd have massive bony loss across the tibia, we'd have all these augmentations that we could add to it, et cetera. And that's why it's a very appropriate question. I think it gets to patient selection for these cases. And I don't use these on every single case. I know that Dr. Ames, one of the Dr. Theologis's partners, uses patient-specific implants, and meaning rods and the inner bodies on every single case he does. I tend to reserve it for folks that are a little bit more like this, that there's massive bony loss, and I need to do something from an augmentation standpoint to hopefully correct, to get my goals intraoperatively. I feel a little bit bad in that regard because I'm throwing my hardest patients to the newer technology and saying, okay, can you help me here? But that's an excellent insight. And each of these levels, whether you go lateral or whether you go anterior, you have to mobilize that segment. Because if you don't, a personalized interbody shoved into not remobilized segment is gonna have subsidence just like an off-the-shelf interbody.
Oh yeah, Dr. Eisler.
Following up on Dr. Chapman's comments, if you were to look at what's contributing to the success of these personalized antibodies, is it the fact that it's customized to the end plates and the lordosis? Is it one or the other, or would you say like you could just as easily get an off-the-shelf implant if you did your pre-op planning and said, I do want 20 degrees for this level, but you know, because your sets don't have this 20 degrees.
Yeah, that's a great question. And the issue is interesting to me because we'll actually look at that intervertebral lordosis, right? And we'll sit there and say at L4-5, I need 16 more degrees, right? The implant that's engineered when we take those segments and we realign them to get that 16 degrees of lordosis never has an inter-implant measurement of 16 degrees of lordosis, right? So it gets back to the idea of mobilizing that segment. In my own practice, as far as using off-the-shelf interbodies, I first started out doing a lot of lateral with expanded interbodies, and I always pulled the 15 degree out of the box saying, hey, I want as much lordosis as I can possibly get here. And I saw so much point loading and subsidence associated with that, I began realizing that if I used the 6 degree cage, often I could affect 12 degrees of lordosis at that segment, because if you pull out a 20 degree cage, it assumes that the center of rotation of that lumbar element is right in the middle of that cage, because that's what the 20 degrees is measured from. Whereas if we actually take the time to reorient the patient's spine into the alignment and the degrees we want from end plate to end plate, the resultant 3D printed interbody is never 15 degrees. It's usually, if you actually look at the intervertebral lordosis of that interbody, it could be 6, but it accounts for the fact that the center of rotation is somewhere in the spinal canal and not in the disc space.
Must move on, but thank you so much, Roland, and look forward to hearing about your personalized iliac screw fixation from the lab soon. Right, there'll be personalized iliac screws. Next, we have Dr. Yashar Yavidan. He's the chief